right. So it's my pleasure to talk a little bit about safety, cost, and value as it relates to clinical decision support and electronic health records. And I'll talk a little bit about CDS itself, some challenges, the requirements that we need for good clinical decision support, and what the future will hold. I made this slide 6 years ago, and I thought I would never be able to use it again. You know how election cycles, things come back over and over again. But this is an interview that Jon Stewart did on The Daily Show with Newt Gingrich, and he said, we believe electronic health records could save literally between 40,000 and 100,000 lives per year. Very powerful meme, and we are starting to look at it a little bit differently. We're starting to look at value these days, and value includes quality and safety divided by the cost that you have to pay for the healthcare. And I think we're starting to pay attention not just to the numerator, but we're starting to pay more attention to the denominator as well. Why do we need clinical decision support? Why do we need electronic health records? Well, I think this is an obvious proposal. We are exposed as physicians to more and more information. The information that we have on patient is increasing. We are now adding genomic data to that, and the ability of providers to manage that information and control the flow of that information and use that information for clinical decision support is limited. That's where informatics comes in to help with that access. And in order to do good clinical decision support, you already heard you need the right information, you need the right stakeholder, it has to be in the right format, through the right channel, and the right point in the workflow. All these things must come together in order for clinical decision support to be valuable. And if we do this, we can improve quality, patient satisfaction, and outcomes. But there are a number of challenges, and that's really what I want to talk to about. Number one is what comes out of the box doesn't work. And I think I see some heads nodding, and I think others have made that same experience. Good clinical decision support is hard to do well. New knowledge changes and requires constant updates. And solutions so far haven't scaled. And at the end, I will talk about a little bit about proposals that are coming out that might open a new way of doing scalable clinical decision support. So what comes out of the box? I don't know if you can see that. See me after class, F. I'll give you this is something that came out of the box. When we implemented our provider order entry system, it came with a drug-drug interaction tool. 15% of all medication orders triggered alerts, so 1 in 7. Of those, the health staff overrode 97.4%. And the scary part is of the remaining 2.6, where they actually responded to the alert, 2/3 of them resulted in new errors. So Plavix and aspirin for patients who just had a cath, is something you want, and you don't want the intern to discontinue one of them. It came with these huge ambiguous messages, screen after screen, that nobody would read, and they're very ambiguous, generally avoid, contraindicated. The alerts were not visible to the pharmacist, so the pharmacist didn't see what the physician had seen. It didn't distinguish routes, so if you had something that was incompatible with a beta blocker, but you'd get a beta blocker in the eye, it still would alert. And after looking at it for 2 months, we didn't identify a single patient safety-related benefit. Nothing, nada. So we built our own. We limited it to a number of drugs that we actually cared about, reduced the frequency of alerts by 90%, and the alerts were clinically irrelevant and were significantly less likely to be overwritten. So it was somewhere around 30% that now were overridden. But it cost us a lot of time and effort. So it's hard to do this. I don't know if you obviously you can't read this. If you're a pediatrician, you know what this is. This is the table of immunizations for childhood. And if you look at this, well, you have some basic ideas when the shots are supposed to be given, but there's so many rules in that fine print down there. In order to translate this into something, it's quite challenging. So we did this just recently at the Harriet Lane Clinic. If you register at our clinic, That information goes into our ADT system, obviously, and from there it gets pulled in our clinical decision support server, where we compare your data with our immunization repository. And then the magic happens, and if you're due for a shot, we page it out to the nurse in charge, who then puts it into the POE system. No direct order yet. So we added all CDC rules, and we extended it to all age groups, and we drastically improved our performance in capturing kids that came for a sick visit, for example, in receiving those. And we are now moving it to the inpatient side as well, because we would like to capture the inpatients as well. But if you build such a thing, and the CDC changes the rules on immunizations every 6 months. So when you build something like this, if every hospital represented in this room were to do this, and every time the rules change it, it comes with an incredible overhead, because somebody has to go in there and touch it and modify it. And we have clinical decision support that constantly change. Cancer brings in, oncology brings in new cancer treatment protocols, immunization rules, other treatment guidelines and policy. Each of these professional societies put all these policies out all the time. New drugs, new diagnostic modalities, all of those changes clinical decision support and changes the way it's put together and requires subsequent work. Joseph already mentioned that what we know about this, the evidence of this comes out of a handful of organizations, and they generally had a homegrown system. And we haven't been able to see scaling of this to commercial system at this point. Bringing value to our patients and to our physicians and hospitals, it requires that we not just blindly enter data in electronic health records, that we enter the problem list. It requires that we secondary use this data, that we do something with that. So that we use them for clinical decision support or cost savings, and that we find ways of sharing our clinical decision support with others and stop reinventing the solutions. So data, of course, are the basic requirements. And I love this quote. I don't know if anybody can figure out how old it is, but I think it describes a lot of clinical systems quite well right now. In attempting to arrive at the truth, I've applied everywhere for information, but in scarcely an instance have I been able to obtain hospital records fit for any purpose of comparison. If they could be obtained, they would show subscribers how their money was being spent. Any idea who said that? Very good. That's exactly right. Yeah, but it could be true today, couldn't it? So clinical databases in the past, I like to think they were like black holes. What the definition of a black hole is. Once you go past the event horizon, nothing ever comes out again. And it is imperative that we change this. We have so much information in our clinical systems, ADT data, vital signs, ins and out, provider notes, nursing notes, order, laboratory data. There's an incredible amount of valuable data in there that we can use. And I'm a neonatologist by training, so no talk without a poopy diaper joke. Databases today, they have to be like babies. What goes in must come out. And I think it's fundamental that we do this in real time. And then we can use this data to provide alerts and reminders on individual patients and performance of providers as well. Give you an example of what is doable. And I've been doing clinical decision support for many years, and I always focused on safety. And recently we wrote an article about money, and I was a little bit taken aback by how much more interest that generated in the press than saving lives is saving money. But nonetheless, we looked at the patients that were in the hospital in internal medicine, and they were on 4 very expensive IV medications. And all these medications, Diarel, Keppra, for example, they have PO equivalents that are very cheap. So we looked at whether these patients were on a diet at the same time they were receiving the medication IV, making them eligible potentially to get this medication PO. And you can see there was a very high number of doses that were given while the patients were already on a diet. And we estimated the cost savings for Hopkins internal medicine alone for those 4 drugs in over a year to be $1.1 million. So now we multiply that by the whole hospital, and by 6,000 hospitals in this country, and you're talking some real money. So now we are, of course, working on an alert to get providers to change their behavior, and we'll see. You keep tuned and see whether we can be successful with that. Other things that when it comes to cost savings, are these days one of the things that we are trying to do is we try to drive throughput, and we had some significant problems in our pediatric intensive care unit. We had lots of elective cases that were canceled. Emergency department had to board patients because our PICU was full. We had fly-by days. And at the same time, while we were rejecting about 20% of patient referrals, we had an average of only 77% bed occupancy. So we needed a better way of managing this in our ICU. So the goal was to have a forecasting tool that predicted the unit census at any given time and dynamically predicted up to 72 hours in the future. So we had a pretty good way of predicting the patient inflow, but we didn't know how to predict length of stay. And we looked at the data available on our electronic systems, and we came up with the POE data, the order data, as a way of predicting discharge. So let me just go through this. We know how many patients are at any given point in the PICU. And we have a very good idea from data that come from ER data, from scheduled operations, how many patients we anticipate to arrive in our PICU. At the same time, we developed a model to look at the orders to predict who is going to leave. And thus, we'll be able, up to 72 hours in the future, to predict who's in there and who isn't. So what did we do? We looked at all the orders and narrowed it down to a number of groups. And you can see ventilator orders, medication orders, transfusion, diet, activity, labs. All these foreign bodies, like an ET tube or a catheter, all these predict somehow the length of stay. So, and we put this all in a model, and I'll walk you through this. This is quite fun. This is little Timmy. Timmy is 8. He came from the emergency room. He has been in the PICU now for 12 hours. And you can see his orders on the left-hand side. He's still getting lots of coags. He is on a vent. He is NPO. He's getting transfused. And all this in medications are non-enteral. They're all either IV or PO. And you can see on his prediction model, he has a better than 89%. He has an 89% chance of being in the PICU for 72 hours or more. A little later, 2.5 days in, you can see his orders have changed. He's now on a clear liquid diet, and you can see the likelihood of him being discharged within the next 48 hours or so is close to 50%. And then at day 3.5, you can see that his orders have changed completely, and he is very likely to be discharged within the next 24 hours. So. So this is going to be is very helpful for us to predict to schedule surgeries, predict inflow into the PICU, and allow bed management downstream. So I talked to you earlier. It's time for us, and that's where the future comes in. It's time for us to share some of that burden of developing clinical decision support. The American Academy of Pediatrics just had a meeting last year, and we followed up with phone calls with a bunch of vendors, and we asked them what they want from an organization like the American Academy of Pediatrics. And there was one answer that was unequivocal, that they all agreed on, that was really a demand. They said, we want organizations like the American Academy of Pediatrics to develop web services that allow vendors to send data to this web service, get answers back for clinical decision support, and integrate it into the workflow for clinicians. We are tired of developing all these things by ourselves. We don't want to implement Bright Futures in our EHRs. We know this is very good, that you have a way of telling physicians what are the age-appropriate things that you should be doing for this 4-year-old that comes in the office. But we can't keep up with it. We can't do immunization forecasting and Bright Futures and this and that. We want somebody who is a trusted source to do this. And the goal of this is that you have clinical decision support that's owned by an expert and shared with others. It eliminates a number of the regional discrepancies, redundancy of the development goes away, and it guarantees that that person who owns it will keep the content fresh and up to date. If you look at the impact that the meaningful use had on scope for vendors, you know why they're asking this. These are slides that I got from Bobby Byrne, who is now a CEO in Chicago. And you look at it, this slide pie was before the meaningful use. That were her estimates. About 35% of efforts was innovation, 30% were customer-specific requests, there were bug fixes, and about 15% was regulation. What are vendors doing now? I don't know what happened with the colors, but 50% of the effort is regulation. It's related to meaningful use. That means all those innovative things, all the customer requests, they were cut down as a result of that. So when we talked to the vendors first, they said, we want if-then statements, we want algorithms and web services, but the more we've been talking to them, the more it becomes apparent what they really want are web services. They want to be able to send all the immunization dates and all the shots that a kid got to somebody like the AAP and get back from them if Johnny is due for their shots. That's what they want. And they were really very specific about it. So they are very interested in professional organizations to play a role in this because they can provide a stamp of approval. They can point to that and say, hey, we are approved, or we are working with this professional group, and it provides content that the end users will use. So I believe that for the future, and I borrowed a slide from Dr. Osheroff, for the future, clinical decision support, which is difficult to do, as we can see on this slide, is something that we will be sharing, and that we will centralize, and that we will be able to be more effective and cheaper in the development. So I'll leave you with the words of our former CMO, World Peace. You have an order set for that, and we'll go off into the future. Thank you.